Good evening, folks. It's 7:35 on Wednesday, the 2nd of June. Welcome to our 15th edition of the biweekly Wednesday webinars. For any of you who have been in dental sleep medicine for any length of time, you know that tonight we brought you one of the biggest names in this field in the name of Dr. John Remmers. Has been doing this for a very long time, and we're just so excited that we could wrestle him from his busy schedule in Calgary to be with us tonight. He's going to bring some very updated information and some new technologies to you. I won't read his whole long CV, but you should know that Dr. Remmers is a recognized physiologist, pioneer, and innovator in sleep medicine. As a world-renowned expert in the field of snoring and obstructive sleep apnea, he has published over 100 peer-reviewed articles in the area of respiratory physiology. As a pulmonologist and clinical professor of internal medicine at the University of Calgary, Dr. Remmers' passion for education is captured in his annual lectures at Spears, Tufts University, and the Pankey Institute. His devotion to clinical care continues at the Southern Alberta Sleep Center, where he maintains an active sleep practice. He's also Chief Medical Officer of Zephyr Sleep Technologies, leading the research, design, and development of innovative products used in the diagnosis and treatment of OSA. Over the past decade, Dr. Remmers has dedicated his research to patient selection for oral appliance therapy. His topic tonight is Beyond AHI and CPAP, OSA treatment planning with Matrix Plus. Dr. Remmers, welcome to the Canadian Academy. Please proceed at your will.
Thank you, David. Good evening, everyone. It's a pleasure to be with you, David, and members of the Academy. I'm just delighted to be able to contribute. I hope I have something to offer. The name isn't going to do you any good. What's going to, and I'm old and hopefully got some wisdom from all of that. But basically, I'm a person who has devoted my life to science in both basic science and clinical science. And that's all based around what we call evidence and the scientific research method. So I'm going to present to you tonight evidence. And if I'm not presenting evidence, I will tell you that it's my opinion. But by and large, we're going to talk about evidence. And I would start by telling you that I have a conflict of interest. I'm Chief Medical Officer of Zephyr Sleep Technologies, which makes an oral appliance titration device, which is out there on the market and has been for a number of years. And so I have a I'm part owner of the company, so I have a big conflict of interest. And I don't think it's going to be a big deal because what I'm going to tell you is mainly just telling you, here's what we found in the clinical trials that we've done so that you can, I think, count on it as not being my opinion. Anyway, let's get underway. We have a common disease called obstructive sleep apnea, and a recent article appearing in Lancet, a first class medical journal, says about a billion people have sleep apnea. And as you know, 80% are undiagnosed. So this is a problem. And here's Bill Dement's view. Bill died recently. He's a father of sleep, not sleep apnea or anything, sleep. And he's at Stanford. He was at Stanford, started everything. And he says, sleep apnea remains the most undiagnosed deadly problem in medicine. So I want to examine that because Bill's was a very thoughtful fellow. Let's start here with medicine. Are we sure it's a medical problem? He thinks it is. I used to think it is, but I think given what I've just shown you there, I think maybe it's a public health problem. Maybe we shouldn't think of it as a medical problem with a dental treatment. That all gets pretty complicated. I think we have a public health problem that we're not making any progress on. So I'll leave that to I don't want to contradict Bill, but that's my view, and I'm going to enlarge on that tonight. It's a deadly problem. Again, we think that's the case. We have associations that I'm going to tell you about between sleep apnea and survival, and but that it's undiagnosed unequivocally. Bill, you got that one right. It is an undiagnosed problem. So there, I'm going to begin with Bill, and here's the association between sleep apnea and mortality. We have years running here on the x-axis. On the y-axis, it's survival. And at time zero, 1,500 people had polysomnograms. They were randomly selected from the state workers in Wisconsin, and nothing was done to them. They were just watched over the next 20 years. And at the very top, you have the little gray line there. Those are the people that didn't have any sleep apnea by the apnea hypopnea index, and that's suspect, but that's what we call no sleep apnea. And then we have severe sleep apnea, and look what happened to them. They meander along a little bit lower than the no sleep apnea for the first 10, 15 years, no problem. And then they fall off a cliff. Look at the mortality number. The percent surviving goes from 95, and in a matter of 5 years, we're down to 60% surviving. Whereas if you didn't have sleep apnea, you're still up here at 95. So that's what we're talking about. And here's a similar relationship here from the Sleep Heart Health Study, NIH. It's the Framingham study, folks, and essentially it's as good as it gets. And here's the association between sleep apnea and the survival probability. So here's over 10 years, no sleep apnea, and here over 10 years, severe sleep apnea. The difference between this study and the previous one is really that the previous study was carried out. There's 6,000 people in this study, but it was biased toward older people, so that the no sleep apnea folks are dying off a little faster than they were in the previous study. But suffice it to say, survival, reduction in survival is associated with sleep apnea. So I say, look, these are associations. I didn't say anything about causality. I didn't say sleep apnea is killing people. I said there's an association, and kind of like with smoking, if somebody, the survival decreases about like smoking 2 packs a day for 40 years. So we end up saying this is a serious medical disease with serious implications. That's my view, and I think lots of people have that view. And therefore we must take the treatment seriously. So now we're going to move over to how we're going to manage this chronic disease. And there are serious medical implications when the apnea hypopnea index is greater than 10. That's where I am. I think 5 is too restrictive, so I say greater than 10. And then I say physicians are responsible for diagnosis and management. That's the way it is in our culture right now. I can't change that. That is the way it is, and they're responsible for it. I didn't say treating, I said managing. They're the managers. Now we have new technologies that are coming on board all the time that influence standard of care, make care more convenient, faster, and better patient experiences. This technology is zooming along here. It's usually slow to be adopted. I was involved in the very first home monitor developed in Calgary that was a valid home monitor. It took 20 years to get that baby going. I was an inventor of the first electronically controlled CPAP, and it kind of took off. And then we had auto CPAP, auto adjusting CPAP. I was the inventor of the respiratory version of that. Together, the home testing and the auto CPAP changed everything. It allowed us to do a home diagnosis and initiate home treatment with CPAP. But it took a long time. So I can tell you that there are forces at play, whatever they are, that make for very slow adoption of new technology. I'm going to make a comment here, parenthetically. As a physician, I'm going to tell you my view as a physician. Hopefully that would be helpful to the dental sleep medicine practitioners who are there. That I say I cannot and must not accept partial treatment. So I don't like saying, well, we got the sleep apnea is not as bad as it was before I undertook treatment. I don't like that. I have a pretty good treatment here called CPAP, and it gets rid of sleep apnea. So uh, I gotta click that. So sleep apneics are not who are not fully treated with an oral appliance, I say should be on CPAP. So I'm turning now to the oral appliance treatment of obstructive sleep apnea. And I say the same standards that apply to CPAP should apply to that. And that's my view. And I don't like saying, oh, well, uh, we've reduced the AHI by 50%, but now we have compliance, which is double what it would be on CPAP, and therefore we have the same treatment. I don't know anything about that. It's not doesn't work for me. I want to know that the patient doesn't have sleep apnea. Sorry, onward here. So I say this is not an arbitrary. These views are not arbitrary, and they're not negotiable. This is the way it is for the people who are responsible for diagnosis and management. Uh, we can't make up our own definition of therapeutic success. I think we try at times, but if you're talking about sleep apnea and getting rid of sleep apnea, it's pretty clear what that is. That's getting the AHI less than 10. And we can't accept a partial treatment. There's no medical evidence to support this. And I say also we can't leave our patients untreated. We think that this disease may have serious implications, so we need to worry about long-term outcomes. That one. The partial treatment, the dentists who offer that may incur some liability and risk. Decisions regarding management are not in the domain of the therapist, the dentist. They're in the domain of the manager of the patient's disease. It's called the physician. And the sleep physician works with the dentist, ideally, to achieve effective treatment. Well, let's talk about another issue. Why is it that 90% of apneics receive CPAP and not oral appliance therapy? Ooh, why is that? And I'd like to have a discussion of that. I'd like for people to have comments at the end, their own opinions, but here are mine. Why do I rely heavily on CPAP? And I do. I invented CPAP, some of the CPAPs, and I love them. Why do I like them? Well, always works! Exclamation point. Then I added here, folks. Really? Now, it depends on what we mean by works. I'm going to come to this. But if you're talking about being an efficacious treatment, having an immediate impact on sleep apnea, it does that. CPAP gets that job done. But does it work in a larger sense? Well, maybe not. We know now that we can't say that. But I like it. This is just a typical dumb sleep physician saying, I like it because it always works. And then I like the treatment protocols. They're understood. They offer standard practice. I know exactly what's going to happen to my patient. I just send the patient down to the respiratory therapist. They're highly skilled. They have my trust. They start the patient on auto CPAP, and we see how the patient does. The problems with CPAP, though, disliked by most patients. It's barbaric. Who needs to have CPAP on your nose all night, every night? That means that there's poor compliance. And I don't like that. It distributes aerosol. And in this past year, I haven't liked that. That's for sure. And I could also say it uses energy all night long. I don't like that either. But the big hitter is right here at the bottom. Not effective. I use the word effective, not efficacious. Efficacious means the immediate effect. The effective includes long-term adherence and use of the device. So we're talking about being effective, that means improving long-term important clinical outcomes. And it's not effective. See the AHRQ report. I'm going to digress here a minute and tell you about about this report. It's the Agency for Healthcare Research in the United States. Top flight. I mean, it's the equivalent of the CDC when you're talking about technology assessment, medical technology assessment. So they issued a draft report. It's being responded to right now. But let me tell you what the draft report says. It says CPAP it's a report on CPAP treatment for obstructive sleep apnea. It's a meta-analysis, all data by an independent governmental agency. Okay, so I don't think you could do better. So here we go. This is going to be true. So the background is that CPAP is based on the change in AHI. You put the CPAP on a patient and look at what happens to the AHI. And in other words, the efficacy, the immediate effect, has been defined as an immediate or short-term elimination of ventilatory disturbances by OSA. Okay, I'm not going to quibble with that. That's just fact. So it starts with a fact. The second fact is that we must not just accept efficacy, but we must look at long-term effects of CPAP on important clinical outcomes like survival, cardiovascular disease, psychosocial measures, diabetes, whatever. But they need to be evaluated. We can't just say, oh, we have an efficacious treatment and slap our hands and say, see you later, patient. No. We have to know that we're using a treatment that will improve long-term clinical outcomes. So the utility also of AHI is being questioned. It needs to be questioned and examined. It's used to define the presence of sleep apnea, but also for severity stratification, and that must be evaluated. So that's what they're going to do in this report from the existing literature. The existing literature does not show that CPAP prescription improves long-term clinically important outcomes. Whoa, don't miss it. So things like mortality, cardiovascular events, and psychosocial measures are not improved. Got it? That's what it says. That's what the literature says. That's what the data shows. Existing evidence does not support the hypothesis that AHI is a valid surrogate for the long-term measures. That's another problem. Maybe AHI isn't what we ought to be using to define the disease and the severity of the disease. They're raising that question. There's no evidence that it is. And finally, the existing evidence does not support the utility of severity stratification by AHI. These are the conclusions. And I just want to stop here for a minute, go back here, and say that with this, you're going to say, oh, well, they didn't include compliance. Oh, well, they aren't using people who, they didn't discard people who didn't use the CPAP and so on. That's irrelevant. That's not what they're trying to do. The question here is, if I, as a physician, sit down and write a prescription for CPAP for somebody with sleep apnea, I do that, and then I use normal clinical practice, will that patient have improved clinical outcomes? And the randomized clinical trials and quasi-randomized studies and so on indicate that I can't count on that, as a matter of fact. And in a sense, CPAP is not recommended for that. If that's what you're trying to do, you have no evidence that CPAP's going to get the job done, improving long-term clinical outcome. So that's an earthquake. You need to know it, think about it, and ask yourself, what does that mean for our field in general, and what does it mean for your practice? So I like that. Now let's say, well, what about oral appliance therapy? Well, I can tell you, we don't have any better data for oral appliance therapy, but dentists pretend, we think that all our patients are going to respond to this therapy. We can put a piece of plastic in their mouth, their sleep apnea is going to go away, and they're going to use it, unlike CPAP, you're going to say, I know you're going to say that, but we don't have any evidence for that. All we can say is that uh, uh, we don't have any evidence that plastic in the mouth is going to improve long-term clinical outcomes of OSA. Then there's the fact that there hasn't been any standard of practice. Remember, I said with CPAP, we have a standard, we know how to do it, everybody agrees on it. Here in oral appliance therapy, we got a bunch of tribes. We got a bunch of people all who know how to do it and teach. So we teach about it and we teach different ways. I look at that as a physician and say, whoa, what's going on here? I mean, what is this? Do we don't have any way to, in some standard agreed upon way to initiate therapy? So that's a problem, I think. And finally, many sleep physicians don't trust the therapist. They don't like to put plastic in the mouth. So I know that. I think it's a bias, but we on the oral appliance side must try to gain the trust for sure. Well, how good is oral appliance in achieving success? I'm just going to show you some data. You haven't seen this before. It's not published yet. It's from our clinical trials. We've done 5 clinical trials. And in our trials, everybody gets a Matrix Plus study and everybody gets an oral appliance therapy. And we look at the agreements between the prediction from Matrix Plus and what actually happened. What was the outcome? So everybody in our trial gets an oral appliance. And we can look and see how many patients get it treated at various levels of protrusion between 0 and 100% of protrusion of the mandible. Okay. First of all, well, we of the 300 patients, we got 84 out here that were non-responders. It's about 25%. So while we're up from maybe 50% to what was an estimate a few years ago, we're getting about 75% who are non-responders. You don't get rid of the sleep apnea. Sometimes it makes it better. Sometimes it makes it worse. Sometimes it doesn't change. But why does oral appliance therapy fail? My view, okay, but it's based upon this data. First is we got people who are not treatable. The 25% who just simply, you can put the plastic in there, pull the mandible forward, and you can't get rid of the sleep apnea. Okay, everybody knows that. You don't like to talk about it. You like to say, well, it isn't 25% in my study or whatever, but this is 300 patients systematically gathered, part of FDA trials that we submitted. And then let's look at, but everybody's different. Look along here. We have a lot of people distributed between 0 and 100%. So what if we pick 70% as our starting point? We're going to say, let's start there. And that's kind of agreed upon. More people do that than anything else. There are all kinds of methods. You know, there's tensing, and there's snoring, awake snoring, and there's speech, and there's all kinds of ways. A Goldilocks method of not too far, not too far back, not too far forward. But let's say we did it 70%. I'm being liberal there. And we're going to start everybody. We're going to do bite registration at 70%. We're going to start everybody at 70%. And if they don't respond, we're going to protrude them more. Well, if I start there, half of the patients will be over protruded. Something like half of the patients. So we have to realize that there's a spectrum of this efficacious protrusive position. This is the number of patients who responded at various levels of protrusion. And I have to tell you, some people, when you over protrude them, they get worse. And we understand that now. We understand why that happens. But these guys here, they're likely to be over protruded, and so that's not good. Then we have people out here near maximum. They may not tolerate it. We don't know that in advance, that how much protrusion we're going to need. And so we really have a need to think about how do we avoid the treatment failures. This is a waste of money, a waste of your chair time, a waste of everybody's efforts. And it certainly gives our therapy a bad name. So we're going to use treatment planning to do that. Emphasize treatment planning. It's a process. by which the therapist tailors to the greatest extent possible, as good as you can do, application of available treatment resources and options for each client's individual goals and needs. Okay, that's a God and motherhood statement if there ever was one. All right. Well, here's the spectrum. We start over here with awareness, diagnosis, right on through to treatment follow-up. In the middle, we stop and we plan what we want to do. This is just a general concept. This is what we do in medicine and dentistry. But the planning allows the therapist to customize, to think about, optimize what we're going to do. Okay, it relates back here to this. We want to know where our patient is. Are they over here in the red, or are they somewhere in the blue? And if they're in the blue, where are they in the blue? That's what we want to know. That's a key part of treatment planning. Okay. It requires valid predictive information. The information has to be based upon prospective clinical trials, not correlational evidence. I'm telling you this stuff because that's truth. So that's life. It's truth. That's if you're going to be in dental sleep medicine, you better understand that. And you can try to predict using any other method you want to. And there's a lot of methods out there taught by lots of really experienced clinicians. And if you think you can employ the method they tell you and you're going to get good results, good luck, because there are no studies, prospective clinical trials on those methods. And I can tell you, a lot of times those kinds of methods don't pan out, like almost all the time. So you have to have evidence that you're going to base your planning on. Evidence. And here's what we do over here on the CPAP side. We get the diagnosis and we want to start the patient on CPAP, put them on auto CPAP for a bit. The respiratory therapist selects the optimal pressure from the auto CPAP. So the auto CPAP's moving the pressure up and down all night long for a week or a month, whatever you want to do. But it's the auto CPAP that's going to give you the optimal pressure for that patient. And then the respiratory therapist will say, oh, that's the good pressure. And here's the interface, the mask that seems to work best for you. And we're going to start the patient on that CPAP treatment with a fixed CPAP pressure. And then we'll do follow-ups. This is the way we do it, okay? We do a titration study here, typically done with auto CPAP, but it can be done in the lab as well. We auto titrate, we figure out what pressure is needed, and we get a best interface, and we give the patient support and starting on that, okay? We need the same thing here with oral appliance treatment, and I think we have it. It's called Matrix Plus. It's an auto-titrating device, which after the diagnosis is made, that enables treatment planning because it will tell you, is the patient going to be a responder or not? If it's one of the 25% over there in the red category, or is it an actual going to be a responder? You're going to get rid of the sleep apnea with your therapy, and if so, how much protrusion do you need? Then, of course, you carry out the appliance therapy according to the information, valid predictive information. I'm going to show you those studies that establish that, and then you do treatment follow-up. Keys to your success is treatment planning before you undertake the treatment, of course. You can't plan in reverse. Deploy methods that are clinically validated. I'm going to show you the evidence-based and that are FDA cleared. All of that's true. It'd be nice also a simple test to do. And then this also allows you, if you're using evidence-based published data to base your treatment planning on, this allows you to gain the trust of the sleep physician. So do we have such a method? Well, I can tell you that we've looked for one for a long time. Let me just digress for a moment. We tried to look at AHI. Certainly that ought to predict whether somebody's going to be a responder and how much protrusion are going to be. No, not at all. Does not. BMI, no. Other clinical features, no. You can put them all together and use artificial intelligence. Peter Cistulli has done that. And he says the results are deeply disappointing. So don't plan to do that. Don't plan to just use your own method and say, this is going to work out just fine for me. No, it's not. You don't have any evidence that it's going to. The other approach, of course, is to image. We got these lovely cone beams. Let's just look at the cone beam and we'll see where the problem is and how we're going to fix that problem. No, the evidence is lacking. We've all tried that. We published on it and it doesn't work out. So there is no simple method to look at an awake patient and assess whether or not he or she's going to respond, and if a responder, how much protrusion is going to need. There's nothing out there. Now, you may have your way. Other people may say they got a secret way to do it. I would be very careful about that. We do have one. So the yes is regarding Matrix Plus. And Matrix Plus, how does it get around it? How does it do it? Well, it does it by studying the patient while asleep and moving the mandible exactly the same way that mimics what the oral appliance does. So it gets real simple. Let's see if it works in real life. And this is important because there's a difference between wakefulness and sleep. When you're awake, you have all sorts of compensatory neuromuscular activities keeping your airway open if you have sleep apnea. So you never block off while you're awake. But even when you're asleep, it's not the anatomy that determines whether or not you're going to have sleep apnea only. It's important, but very important are neurological factors. The narrowed airway of a sleep apneic is in the sleep apneic. It's in a human being. And there are neural factors called endotypes, high loop gain, arousability, and muscle activation that very much determine whether or not you're going to have a response and at what amount of protrusion you're going to have a response. So this is the only way that is available, that has published evidence. We have 3 clinical trials, all published. The last one is just being reviewed right now, but we have lots of evidence for you that will predict who to treat and how to treat them. And there's going to be just a little body-mounted computer, and there's going to be a little tablet at the bedside. Here's the old Matrix Plus. Matrix was actually an in-hospital test, and then we came out with an in-home test, and that became Matrix Plus. And this was the original Matrix Plus. It's been discarded now, and we don't have the flow anymore. Well, that's cool. That means that we don't have the patient suffering from the discomfort of catheters up the nares, but also it's a lot more reliable study because the airflow signal is an unreliable signal. It fails at part during the night, and and so we got rid of that, and now we simply have a mandibular positioner. We have these temporary trays in the mouth being moved by a motorized mandibular positioner, and the information that the positioner is gathering is just from the oxyhemoglobin saturation, the oximeter signal. That's it. So Matrix Plus is now nothing but a motorized mandibular positioner being driven throughout the night by O2 saturation. So it's an oximeter and a positioner. That's it. Here's the kind of data we get. I want to pause here and mention my collaborators, and particularly one, Curtis Vesterson. This is our third, called Notice 3. It's our third study, and Curtis was the dentist, the research dentist in this trial. So we had 60 or so patients, FDA trial, was submitted to the FDA, accepted by them. But Curtis was the man who set up the trays. If you want to know about doing that, you call Curtis Vesterson in Calgary, and he'll tell you. If you want to know how it went, whether it was hard or not to do the studies, ask Curtis. and he'll tell you. But here's the results of the study that Curtis did. And Curtis was, by the way, blinded. He didn't know what the results of the Matrix Plus study was. Everybody gets a Matrix Plus study in the home, and then a prediction is made automatically by a computer, and then Curtis went ahead and fitted everybody with an appliance. It was a ProSomnus appliance. It was adjusted according to protocols but he didn't know who was going to be a winner and who wasn't. And then we look at the agreement. We do outcome tests with the custom oral appliance in place and compare the outcome with the prediction. So the patient was predicted to be a therapeutic responder. We can see if the patient was a therapeutic responder, and that's what we have right here. Here are those patients who are predicted to be a therapeutic responder, a therapeutic success. And on the left here is the baseline ODI going from 10. You had to have an ODI, an oxygen desaturation index, which is more reliable than the AHI. That's why I use it. Greater than 10 and up to whatever. We went up to 110 here. So we have this spread at baseline, that is to say, diagnostic study with nothing in the mouth. Here's where the patient is normally during sleep, 2 nights of sleep. And then when Curtis put the oral appliance in the mouth and we did 2 nights of sleep, here's where they were. All predicted successes were less than 10. All of them had a therapeutic response. Well, that's not easy, folks, to have something that's 100%, but we got 100% there. So the mean value was 5.8, but it isn't the mean value that we really care so much about. We want the predictions to be accurate, and they were very accurate. That gives you something called a specificity that was 100%. Over here, we have the people who were predicted failures. The computer says, this guy has put the custom oral appliance in his mouth, and I can tell you he's not going to have an AHI or an ODI below 10. At baseline, here, they're similar to these guys over here, but they aren't nearly as good of responders. Just look at the people in red first, because they're the ones that are correctly predicted. Here's a guy up at 100, no change, stays 100. Over here, though, we got a guy at 110, and he went down here to 5. Big difference between this patient and this patient. And it's not the ODI or the AHI that distinguishes them. It's their response. It's their prediction by the Matrix Plus test. So no response, down, but not enough. So all the ones in red were correctly predicted. And then we have these troublesome 4 guys in blue that were incorrectly predicted. They actually had a outcome, custom oral appliance in place, outcome value less than 10. So we're not perfect. It gives you a specificity of about 90%. All right. What about, and the mean value is 82 here and 5 over here. So you can see there's a lot of people over here that you just as soon not treat for sure. What about accuracy in determining the efficacious position? So each patient has a prediction of here's where you set the mandible and you'll get an efficacious response. This is only on predicted responders now. And so here we are, and 85% of the time, the predicted position was in fact adequate. So I have the predicted efficacious position here on the x-axis, on the y-axis, the actual efficacious position. This is how much protrusion it took. And you will note, if you're on that line, that the predicted equaled the actual effective position or efficacious position. And we had these 6 that were up here. They required a few more millimeters of protrusion. So most of the time, you can put the patient at the predicted efficacious position, and you'll get an AHI less than 10. I'm going to close here by saying it's all about patient experience. I believe this, and I'm sure I'm preaching to the choir when I say that. But we want decreased time to treatment. Physicians want this, you want that, But I particularly want it because that's what I have with CPAP. I want less time off work. I want the patient sleeping better. And we think that it may be that if you are doing the bite registration and constructing the appliance at the efficacious position, that you in fact increase the likelihood that you're going to have a good treatment outcome. And most of all, we have confidence. The patient develops confidence, the referring physician develops confidence, and maybe that leads to better patient adherence. Okay, but certainly we're more efficient, and I'm going to say we can. That allows us to treat more money, save money on unnecessary and prolonged treatment efforts, increase reproductions, and drives referrals with as a result of the excellence in patient experience. That's again is our experience in life. I'm going to present you one case, and then I'm going to close. But this is just shows you why you need to use a matrix plus in your practice. 46-year-old male, he's skinny, 27 BMI, baseline ODI 117. His AHI is very close to that, 117. And he's currently using an oral appliance, and his ODI was 34. So he had partial treatment. Whoa. So here we have a guy with very, very, very severe sleep apnea by the usual standards. He's not very obese or anything. He's got very severe sleep apnea. And he's using an oral appliance out at maximum, and he's still got severe sleep apnea by the usual standards. And that's the best we can do for him. That's what was going on before the patient entered into our clinical trial. So he was invited to participate in the trial. He did participate in the trial, and his study looked like this. In this trial, we were still using airflow. The black here is air. This is the full night, I should say. This is the full night record of the study. At the top is the mandibular positioning. Okay. If it goes up, that means more protrusion. Down, less protrusion. Oxyhemoglobin saturation, airflow, pulse, chest movement, and snoring at the bottom. All we really have to, and the gentleman is on his back the whole time here. That's what the purple says. So here we go. This is the first night of a 2-night study. He starts at the habitual bite, the horizontal dashed line here at -1 is the habitual position. And this is the maximum position up here at about 7, all relative to edge, by the way, of the incisors. So we start here and move out, step out, out. The computer tells it to move out because there were some respiratory events, and then it moves back down, then it moves out again in response to respiratory events, then it's back down. So it's in and out all night long. That's the first night. We call it a dynamic night. And it's just doing this. The patient does not wake up. We've studied this. Arousals do not happen with these 0.3 millimeter, 0.2 millimeter movement of the mandible. Okay, we do a second night then to confirm what we're thinking. From the first night study, we think, oh, he's going to be a responder out here at about +3. And so we first move the mandible out to +3 and hold it there. Hold it there pretty much all night. Out here, we step it up again a little bit. And we can see each of these gold bars is a respiratory event. And you can see that he cleared right up. And for most of the night, he had no respiratory events. This is the gentleman that has an AHI of 117. So what's going on here? Well, the computer tells us. Nobody interprets this. No physician's looking at it. The computer's telling you, the therapist, says, this person's going to be a responder. Now, you already know this guy's on an appliance at a maximum, and he is not responding. Out at maximum, he's got an ODI of 34. So, whoa, this is pretty surprising. This guy's supposed to be a responder, meaning his AHI and ODI are going to be less than 10. And he's going to be a responder at something like 50%, 54%. Okay, do we believe that? Probably not. That's too good to be true. So, but Curtis did the job. He put the appliance in his mouth, set it at 54%, and we did a follow-up home sleep apnea test, 2 of them, ODI 1.7, 117 to 1.7. Whoa. And when he was out here at Max with another oral appliance, he was 34. So there's a minimum value here. If you over protrude this, and this is because the gentleman fundamentally has high loop gain, high chemosensitivity to his reflexes controlling breathing. And we can just say that, look, if you get right in the middle, you unobstruct him, but don't over protrude, you're going to be good. 1.7 is the ODI. But if you carry on and protrude him out to maximum, bingo, you're going to get severe sleep apnea again. So that's the case, and it just points up how important it is to select your patients appropriately and to utilize the efficacious position that's given you. What do I expect? I expect that my therapist will use evidence-based methods for treatment planning to avoid treatment failures. My therapist will provide expeditious therapy, and my patients will be treated with respect and good service. These are all things that I know you would adhere to, that I, as a referring physician, expect. But what I don't want is my patients to be subjected to guesswork, uncertainty, dark art, snake oil, I don't know, whatever you want to call it, but stuff that is not, is based upon evidence in prospective clinical trials. That leads to out-of-date clinical practice, prolonged titration experiences, and I think overall a bad patient experience. I'll, of course, refer my patients exclusively to dentists who are well-trained and use a validated treatment planning. I think we're at a tipping point. I do believe that, and that may be the case. I'm not trying to sell you a bill of goods here. I believe that may be the case. We've been having problems really because CPAP was unassailable. CPAP was it. And clearly now we know that there is no evidence to think that. I'm not saying CPAP can't do the job or whatever, but the evidence we have is that if you write a prescription for CPAP and start the patient on CPAP, you will not improve long-term clinical outcomes. So I think more and more people are going to turn to oral appliance as we don't have any proof that oral appliances are going to improve long-term clinical outcomes either. None. But at least it's a less barbaric, more acceptable, and treatment that has better compliance. So that's my view. I'm going to stop there. It's just about what I said. So I say Matrix Plus is the only way to provide treatment planning for your sleep patients. And that is true. I think it's the only way to go. It's the only way that you can do it rationally. I call everything else dark art. You can call it what you want, but if you're going to use your clinical judgment, if you're going to use the clinical features like AHI and BMI, or you're going to use your cone beam, you're practicing the dark art. Now, there are a lot of superb clinicians who do a lot of teaching and have their own following and have their own kind of messianic missions that they're on. They won't agree with that. They say, no, I can do it. And then you ask them, I do all the time. Where's your evidence? And usually it is, well, I'm gathering it. I'm taking all my patients and I'm going to write a paper one of these days. First of all, that's not prospective. It's correlational. And then they're going to tell us that everything's okay with the way they do it. If you buy that, I've got a bridge I want to sell you. It just doesn't work out. Life in clinical science doesn't work out that way. So I'm going to stop there. This last bit I'm not going to do. I do say to emphasize that Matrix Plus enables a fully digital workflow. I don't know the details of this. I'm not a dentist, but that's what I'm told. But I'll say it's idiot proof. It's simple at-home technology. It's just a mandibular positioner plus an oximeter. It's real simple. It works pretty much every time. We don't have a lot of failures. It's very solid technology. There's bedside instructions using the tablets, the tablet-based videos. It can be successfully used in the home by patients with very little instruction, very little effort from your office. And we have cloud-based transmission, analysis, and display. That's all to be expected. We have all that. We have over 5 clinical trials, 1,000 tests, FDA cleared, demonstrate durability and reliability in the field. All of that is true. I can tell you all of that is true. Concluding, commonly used methods in awake patients, i.e. clinical features and pharyngeal imaging, appear to have little predictive power in selecting patients for OAT, for oral appliance therapy, and for guiding the mandibular position. Oral appliance titration studies during sleep have strong accuracy in predicting OAT outcome and an efficacious mandibular positioner in those predicted to succeed. At home auto titrating sleep theranostic is now available. It's called Matrix Plus. It's made by Zephyr. If you want to know more about it, you can go to the Zephyr website. You can get a hold of me. I am at jremmers@zephyrsleep.com. So my name, jremmers@zephyrsleep.com, or just go through Dr. Rawson and he will put you in touch with me. I hope you've enjoyed the webinar and love to open up to some questions. Thank you very much.